What's up, everyone? Welcome back to part 2 of our pediatrics quiz. If you haven't seen part 1 yet, check it out. Otherwise, let's get started. So, we have a 2-year-old female presenting to the ED with a 3-day history of rhinorrhea, cough, and low-grade fever. Upon exam, she becomes scared and anxious and starts crying, and as she pushes you away, you hear a high-pitched breath sound. What is the most likely pathogen causing this patient's symptoms? So you need to know what symptom is specific that's going to lead you to the proper diagnosis. So in this case, it would be that high-pitched breath sound. And what does that make you think of? Right, stridor. And so which one of these would you consider the pathogen that leads to the stridor? So which one of these pathogens most likely is associated with that stridor, as well as generalized URI symptoms? Is the answer parainfluenza, pertussis, influenza, or adenovirus? If you said parainfluenza, you'd be correct. And what does this kiddo have? Right, croup. And so if she coughed, it might even sound like a barking cough. So those are the two things you want to think about with croup: is inspiratory stridor, barking cough. On chest x-ray, what would you see? Right, the steeple sign. So for our listeners at home, right now we have chest x-ray up. On the right-hand side, you see a steeple sign, and that is significant in croup. On the left-hand side, we actually have an unrelated chest x-ray, but I thought was a good learning point as well. You see this little thumb sign or thumbprint sign, and that would make you think of something else. Right, epiglottitis. So epiglottitis, thumbprint sign, croup, steeple sign. Fantastic. So next question. A 6-month-old is brought into the ED with concern for a broken arm. Mechanism of injury is secondary to a brother who's about 8 months older jumping off the couch onto his arm. When you get an x-ray, it shows a spiral fracture of the humerus. What is the most likely underlying cause of this fracture? And you must be thinking, oh, well, you just said the brother jumped on the arm, so that's it. But let's dive into it a little bit more. So our answer choices are non-accidental trauma, accidental trauma, crush injury, and self-induced injury. So do you think a 6-month-old is leading to self-induced injury? Probably not. Crush injury, maybe. It's a little vague, not really sure what they're getting at, so let's hold off on that one for now. We also have accidental trauma, which this case would probably fall under if you believe the story, and then non-accidental trauma, which I would argue is the correct answer here. And we have a couple reasons to be concerned. One, the mechanism of injury of a 14-month-old jumping onto a 6-month-old, it doesn't really make sense. By 12 months, you think about kiddos just starting to learn how to walk. So when you think a 14-month-old is jumping off a couch, it makes me suspicious. And then second, the x-ray. The x-ray shows a spiral fracture, which when you think spiral fracture, you should think about mother tugging on baby's arm, twisting it, causing this fracture. So in this case, if you had someone jump on the humerus, you would think of a more typical break. So because of those two things, I would argue non-accidental trauma is the best answer choice. And you can think of other things. What else do you think about with non-accidental trauma? Right, you think about hematomas in the brain. You think about retinal hemorrhages. You think about rib fractures and burns and just horrible things. So always keep those in the back of your head. For the USMLE exam, they love to test this, so always have that kind of as a differential. All right, next question. Select all answer choices with correctly matched tumor/characteristics. So this is tough. So we have 4 tumors in the CNS. The first one, craniopharyngioma. Is it associated with visual defects? Ependyoma. Is it associated with increased cranial pressure? Astrocytoma. Is it associated with malignant transformation? And medulloblastoma, is it associated with ataxia? And I know there's a lot of overlap. I just wanted to go for the highest yields, the things that I think they would use to differentiate where the cancer is. So craniopharyngioma is found around the pituitary. So I think about it a lot as a pituitary cancer, even though technically it's not. So craniopharyngioma, visual defects, of course, because you're right there at the optic chiasm. It can also lead to endocrine disorders as well because of where it's located in the cella turcica. So craniopharyngioma, visual defects makes sense. That would be one of the answer choices I click. Ependymoma, increased cranial pressure, that also makes sense because those ependymal cells are actually creating CSF, so you might have more CSF production, and then also they can clog the channels, causing an obstructive picture. So it can be almost a mixed picture at times, and that would increase the cranial pressure. Astrocytoma and malignant transformation, this is actually the incorrect answer. I'm sure there are cases where astrocytomas do undergo malignant transformation, but for the most part, these horrible cancers are so locally aggressive that they kill a person just from how they interact within the brain, just their local effect. So malignant transformation may be pretty rare for these cancers. These cancers are really just devastating within the brain. And the medulloblastoma, remember, those occur kind of in the infratentorial area and often around the cerebellum, so ataxia would be appropriate for those. So, next question. A 14-year-old child presents to your office after summer break with hypopigmented macules across her back. What is the next best step? And you're thinking, I hate these questions because I never see the lesions. So let me show you a picture. For those listening at home, we're looking at a picture right now. It is of someone's back, and you just see a scatter of hypopigmented macules, even some coalescing into hypopigmented patches. And so you see this, and you think about a couple things. For me, I think of versicolor, tinea versicolor. I also think about vitiligo with any hypopigmented patch. So let's go to the answer choices. So, what is the next best step? 1. Education regarding avoiding the sun. That's always good, but I don't know if it's the best answer for this. Antifungal shampoo. Good if you think versicolor. 3. Autoimmune workup. Okay. And 4. Shave biopsy of affected skin. All right. Seems a little aggressive on a 14-year-old particularly. So 14-year-old summer break hypopigmented macules, I would say best choice, tinea versicolor, especially with the picture we just saw, we would give an antifungal shampoo. Education regarding avoiding sun, although generally a great thing to do, is also put in here to have an education point regarding vitiligo. If this was vitiligo, you would want to educate them that this tissue now has no protective pigment in it. And because of that, you can get sunburn quite easily with a tissue that has these vitiligo changes. So you want to be extra protective of that tissue. So education regarding avoiding sun might actually be an appropriate answer if they had vitiligo. Autoimmune workup, I don't think it's a great answer choice here. And shave biopsy, I don't think will ever be the best answer. But who knows? Maybe for a BCC or a squamous cell. All right. Next question. We have an 18-month-old, 2 episodes where she stopped breathing and turned blue. Further questioning revealed that the girl was crying prior to these episodes. The first occurred shortly after she tripped over a toy and fell, and the second was when the brother grabbed her favorite elephant from her hands. A complete workup and physical exam is stone cold normal. What is the etiology? I'm going to skip all these answers and just say this is a breath holding spell. So these are common. Kids typically grow out of them around the ages of 3 to 5, but it's a diagnosis of exclusion. So you need to rule out other big, bad, scary things that can lead people to stop breathing and can cause people to become cyanotic. Those include cardiac arrhythmias. Those can include pathologic GERD, and those can include, most likely, the thing that you're going to confuse this with is some type of seizure or epileptic episode. So you need to rule out all of those bad, scary things, and ultimately you'll be left with breath-holding spells. Next question. You have a 9-year-old non-vaccinated male who has new pain behind his ear and a tender rash noted around his neck that descended down to his shins. On exam, he is noted to have swollen lymph nodes behind his ears and an erythematous tender rash. Select all the potential complications from this pathology. So you need to know what is going on and what would you say is the most likely etiology of this constellation of symptoms? Right, rubella. So then you think, well, what can rubella cause? Is it often a cause of pancreatitis? I would argue probably not. Polyarthritis? Yes, we know that rubella can cause arthralgias. Sensory loss? Yes. Sensory loss both in the extent that it can cause vision changes, with cataracts, among other things. And it can also cause hearing issues. So, vision and hearing, think rubella. And congenital heart defects, yes, I think most likely PDA, but probably can cause multiple. So, heart defects, correct answer. Sensory loss, correct answer. Polyarthritis, correct answer. Pancreatitis, probably not the correct answer for rubella, but a good teaching point that mumps is associated with pancreatitis. All right, next question. 5-day-old infant brought in by her mother who's anxious that she's lost weight since birth. Today she's 7.28 pounds, down from her birth weight of 7.72. Otherwise, she's happy and eating appropriately. What is the best response for this mother's concerns? Is it 1, this is normal and we expect the infant to continue at this weight? 2, this is abnormal and we should increase the feeds? 3, this is normal and we expect the infant to regain weight by a couple weeks? And 4, this is abnormal, requiring change in feed composition. So, this is normal. And do we expect the weight to remain the same or start creeping back up? The answer is start creeping back up. So, kiddos are expected to lose less than 7% of their body weight after they're born. So you can see a kiddo's born, they start dropping their weight a little bit, and then they start regaining it. By 2 weeks, they should be back to at least their birth weight. In this case, you had a drop from 7.72 to 7.28, so much less than 7%, and therefore this is normal. If the drop in weight was greater than 7%, you would want to address feeding and see what can be changed and what can be improved. All right, next question. An infant presents with febrile seizures. Only other symptom that the parents have noticed is some bloody loose stool. What is the inciting pathogen? So this was actually a surprising question that I got during the podcast, and Bobby stumped both Heather and myself. And this is something you kind of just need to know, and something I've never known until going over this podcast. But basically, there's a certain bug on this list, Salmonella, Campylobacter, Norovirus, and Shigella, that is more likely to cause febrile seizures. And the answer is Shigella. So if you see febrile seizures, bloody stools, think Shigella. Salmonella, not so much. Campylobacter, remember that one is a common cause of bloody diarrhea. And if you're going to get a question about that, it's going to be Campylobacter and probably reactive arthritis. And then norovirus is the one that we know causes copious, horrible diarrhea, but it's not really bloody. Those are the ones that are very infectious and can be on a cruise ship, among other places. So the best answer here is Shigella. Next question. A 13-day-old male presents for a weight check. Weight is down 3% from her birth weight. Total body jaundice on physical exam is noted. No scleral icterus, no hepatosplenomegaly, elevated total bili, but a direct bili that's within normal limits. What is the next best step? So, just a review. 13 days old. Weight is a little down, 3%. What did we just say about weight being down? Sometimes it's fine. Jaundiced, elevated bili, largely indirect bili since the direct is normal, and otherwise fine. What's the next step? Right. Just continue to monitor, continue normal feeding. This is probably, most likely, breast milk jaundice, meaning that this kiddo is getting breast milk. Their liver's unable to adequately metabolize, and therefore bilirubin increases in the blood, which is fine. If the bilirubin gets too high, then you start things like phototherapy and transfusion, or if the kiddo is symptomatic. But otherwise, keep doing what you're doing. You're going to be fine. If it's breastfeeding jaundice, and so breastfeeding occurs before breast milk jaundice, breastfeeding jaundice within the first week, breast milk jaundice within the next couple weeks. We just talked about breast milk jaundice. But breastfeeding jaundice is a different issue. It's actually that the kiddo is not receiving enough milk, and that causes the body to reabsorb bilirubin. So in that case, you actually want to address the feeding. So breastfeeding jaundice within the first week, and breast milk jaundice a couple weeks later, different etiologies, different manifestations. That's kind of what you need to know, at least to break them down for the USMLE exam. I'm sure it's much more complex than that, but that's how I remembered it and how I was able to separate them in my mind for this exam. So, next question. A 15-year-old female with type 1 diabetes presents with months of fatigue and weight loss. Physical exam is significant for a skinny girl with a vesicular rash on her extensor surfaces. Labs are significant for a microcytic anemia. The treatment for this condition is what? So just to summarize, because that's a lot. You have a 15-year-old, she already has diabetes, but now she's more fatigued. She has some weight loss. She's skinny. She's got this rash. And she has microcytic anemia. So initially you might be thinking, oh, she has diabetes, this is probably a diabetic complication, but there's a lot of stuff here, and I'm not sure everyone can be explained by diabetes. So the answer choices include improved glycemic control. Okay, if you thought this was a diabetes issue, perhaps that's the right answer. Iron supplementation. If you thought this was just an iron issue, that would be an appropriate answer. Altering dietary habits. If you think this is a GI issue, that might be the right answer. Colonoscopy, again, perhaps this is something like IBD, and you think, oh my gosh, do we need to actually see inside the colon? That would be the correct answer. I'll give you guys a second to think about this. This constellation of symptoms can be explained by one disorder, and that's celiacs, right? So they already have a history of autoimmune disease with type 1 diabetes, so that can give you some pretest probability that maybe they can get another autoimmune disease such as thyroid or celiacs. The physical exam shows signs of malnutrition, perhaps because they're not getting enough nutrition because of their celiacs, and the microcytic anemia also points you towards that etiology as well. And the final thing that should push you over is this rash. So we have an image of this rash. Here you go. Vesicular rash, often on the extensor surfaces of extremities, most classically on the elbows and knees. You can also have it on the lower back and on the neck as well, so don't let that confuse you. It can really be anywhere. We just most commonly think about it on the extensor surfaces. So this kiddo does have celiac, and therefore the correct answer is altering dietary habits, and that will go away. There is a rare case where you need to use dapsone for symptomatic treatment, but for the most part, just stop consuming gluten. So, final question. A mother brings in her newborn infant concerned for a bruise on the lower back. The physical exam is noticeable for a blue-gray, evenly pigmented patch on the sacral spine. I'll say that again. Blue-gray, evenly pigmented patch on the sacral spine. The next best step is, do you call Child Protective Services? Do you get an MRI of the spine? Do you biopsy the lesion, or do you reassure the mother? So what do you think this is? And I would say this question is probably not entirely fair unless you had an image. So let's look at an image real quick. And here, for the listener at home, we're looking at the lower back of an infant, and here you can see an annular patch across the infant's lower back, showing kind of black to dark blue discoloration. What is the name of this lesion? Well, colloquially, it's called the Mongolian spot, but its actual term is congenital dermal melanocytosis. And it's a benign lesion. Just monitor, reassure the mother, but nothing to do. No MRI of the spine, don't biopsy it, and definitely don't call Child Protective Services. All right, guys. Well, that is it for today's quiz. I hope you guys enjoyed. This was part 2, so if you missed the first 10 questions, go back and watch part 1 as well. A lot of great diagrams in that one as well. If you like these kind of exams, make sure to come up here and go to Ace the Boards, and you can see that they have at least 5 exams right now and at least 10 by February of 2021, so hold me to that. And we have other things. If you have peers and taken step 1, we have some actual practice exams that are based around Alexa, so they can actually download the app there. And of course, if you like the podcast, you can get to it from our website as well. Buzzwords, the med school drinking game. All right, guys. Well, until next time, have a fantastic day and a wonderful week. See you guys soon. Bye-bye now.